Good morning, everyone. Thank you so much for joining today. We're going to give everyone about a minute or two more to join, and then we'll get started. Thank you so much for being here. Good morning, everyone, and Happy New Year to you all. Thank you again for joining us. I'm Samantha Mokas, and I work with FACOS as the Director of Member and Partner Services. We are so excited for this opportunity to present to you the next installment of our free webinar Wednesday series, the many aspects of population health management presented by our business partner, InfoMC. Before we get started this morning, I'd like to go over a few items so you know how to participate in today's event. You should see an attendee interface on your computer desktop in the upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join in over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during this presentation. We will collect these and address them during the question and answer sessions at the end of today's presentation. With that, I would like to introduce to you and turn over the presentation to John Kadish.
Well, hello everyone. I hope everyone had a great holiday. And for those of you whose New Year's resolution was to attend more seminars and webinars, I'm glad we're able to help you out with that. So just to give you a little bit of background on myself, originally I came into the healthcare field working for an insurance company back before we did really much in the way of managed care, and I was trained as an underwriter and worked in business development for a number of years. Ultimately, though, I wound up at United Healthcare. I started there in 1989, and in 1991 I started running their behavioral health subsidiary, which was United Behavioral Health at the time. And I did that for about 7 years, and very interesting experience working for a company that has a tremendous amount of resources. So, but ultimately I wound up leaving United. I worked for Centene Corporation, which in Florida I believe is the Sunshine Health Plan, and also ran the public sector for Value Options, managed mental health care carve-out company, which is now Beacon Health Options. So retired from management really about 3 years ago, but have continued to consult, work on various boards, work with 3 private equity firms where I look at deals and get involved on their boards. And I've also taken a couple of interim roles that are, really relative to this presentation. One, I ran a behavioral health partnership here in my now home state of Colorado, which was Community Mental Health and Value Options Beacon. I actually ran the partnership on the ground as opposed from my old role at Value Options. It was very interesting, a Denver region. And last year I did some work for 10 months back with Centene, my old employer, helping them reorganize their what they call Encore and their specialty division with kind of an emphasis on integrating behavioral health and others. So that's some of the basis for this presentation. So what I'm going to talk about is the title is The Many Aspects of Population Health Management. And we'll talk about what some of the dimensions of those components are, problems within the current healthcare system that are adding to the challenges of that management task. The idea that comorbid conditions have a very significant impact on overall costs, and kind of ironically, as you'll see in the slides, some of the impact on medical diagnoses, chronic medical conditions of a comorbid mental health condition, all the costs show up on the medical side. So one of the reasons why we're starting to move, I think, within all the states to looking at people much more holistically. We'll talk about some of the partial solutions. I don't think there is a total solution to some of the challenges of our healthcare system, but there are certainly many, many things that some people are doing a lot better than others, and ways that we can continue to improve it. We'll talk about the social determinants of health, which really over the last 2 or 3 years has become a major focus. I know when I was doing my work last year for Centene, I helped them with proposals in 4 states. New Mexico and Colorado were really focused on the social determinants of health and how the health manager was going to interact and incorporate elements of the social network into their overall plan. So we will talk about that, why managing these things is important, and we'll talk about some of the things that you need to measure, like the key performance indicators and the transitions of care. So let me move on to my first slide, which didn't happen. Sam, oh, there we go. Okay.
You're good to go.
There we are. First, some of the quality challenges that are facing the healthcare system is that about 20% of our primary care physicians don't feel that they're very prepared to identify and treat substance abuse disorders. And then from a patient perspective, only about 13% of behavioral health patients and 5% of substance abuse get minimal care. That's according to a study that's referenced in the back of this. In addition, we have something that's in the press quite a bit, but there are 123 people a day in the United States that commit suicide. Even adding to that tragedy is the fact that a large number of them are veterans. So major problem there. People desperate to address that unfortunate statistic. And something that I think we've known for quite a while, but if you're seriously mentally ill, your lifespan is going to be significantly shortened by preventable medical diseases. So if you think about it, if you're depressed, the likelihood that you're going to follow through on your prescribed course of treatment, taking your meds on time, getting exercise, those kinds of things, diminishes. And so a lot of the problems show up as a medical illness, not so much, the cost of treating depression. The other thing that I think has got to be a significant factor in the shorter lifespan is that 50% of all the cigarettes smoked in the United States are smoked by people with a serious mental illness. We all know that leads to a shortened lifespan. Just a quick, I won't go through all of this, but just some statistics that were put together by Milliman, I tend to focus on Medicaid, but all of these different categories are important to different insurers and risk takers. But as you can see that if you look at the Medicaid, somebody with with a chronic disease but no behavioral health diagnosis in this illustration runs about $381. If they have a comorbid behavioral health, that's going to be about 1,300 or 341% higher costs associated with that individual because of complications that comorbid condition creates. So just reviewed the comorbidity, but it doubles the medical spend on average. The other major challenge that we have here, well, universally in our healthcare system is I think there are something like 30 to 35,000 psychiatrists in the United States. The average age is something like 57. A significant percentage of psychiatrists have gone private pay. So we have and have had for quite a while a significant shortage of psychiatrists. And by 2025, that problem is only going to get worse. And you can see the range of that shortage. So there are some initiatives underway to help increase the number of psychiatrists available. And certainly technology with telemedicine is helping, but there's just no way that we aren't going to be short of that resource. And then from a risk management standpoint, if you're an organization that's taking risk for a population's health, these social determinants that I'll talk about in a minute are just one more complexity that's been added to that whole mission, that you have to look at housing and diet and social support systems in addition to the traditional medical claim kinds of things to truly gain control of an individual's health and the costs associated with treating them. So how does an integrated care approach deal with these challenges? Well, first of all, it looks at the whole patient, not a collection of discrete diagnoses. It's interesting because Value Options was, and to a great extent still is, a behavioral health carve-out company. My personal view is that focus on a single set of diagnoses is not a great opportunity going forward. Those companies, and Beacon now is doing that by building these technologies, working really hard at integrating with the medical side of things. But it used to be not that many years ago where you could have an oncology vendor, a behavioral health, a pharmacy. All of that was considered kind of discrete areas of expertise. More and more so, we are looking at making sure all of those elements are kind of managed simultaneously. So that involves using metrics, what's working, what's not, making sure that you're treating people consistently, following medical necessity guidelines. And you have to make certain that all of the relevant information related to that individual, all the medical, all the behavioral, all the pharmacy, and now many of the social determinants of health are all available to the people that are putting together the treatment plan and trying to coordinate care. So it's much more of a team effort involving a lot more people and a lot more data. Now, the social determinants of health, I think we've heard a lot about this. I don't want to go through all of this in any great detail, but if you look at the headers on this slide, economic stability is a major factor, whether they're going to fill their prescription, whether they're going to receive the kinds of supports around them, whether they have, challenges with supporting their own families. Those are stressors and things that can impede people taking care of themselves. Housing, the neighborhood and physical environment, these are, major influences. If you're a homeless person, for example, you don't have any place to store your meds. You probably have a lot of things going on in your daily life. Not a good environment whatsoever for getting well. And in fact, one of the initiatives that Centene, when they bid here in Colorado and addressed the issue of social determinants, at least one element of it, was that post-discharge from a hospital, it's really important that somebody have a safe place to complete their recovery. We get people out of the hospital so rapidly now, but if they don't have a good, safe place to go, it often results in rehospitalizations and things. So one of the proposals was to build a relationship with an organization that does just that, provides kind of a convalescent housing situation. So a lot of aspects of care that historically we haven't had to think a great deal about, but that more and more we're convinced drive the cost of care and outcomes to a greater and greater extent. With respect to education, I think literacy is one that's really important, and in some part, it's how well do you even understand your medical condition and the instructions that you're being given. So in this context, it's kind of specific to your health literacy, but also, what other resources could be available. It's good to understand. You're not going to say, well, you need to go use this website if in fact that website might be beyond sophistication of the person you're directing there. Food, diet, even with food stamps and things, a lot of people are not eating an appropriate diet, particularly if you have health problems that can be aggravated by what you eat. So that's something, we've always been concerned with, getting a dietitian to consult with an individual, but it's part of the overall treatment planning now, a factor that needs to be considered and documented. The community and social context, here's, really where family support, other friends support, things that encourage you to maintain your commitment to good health and to your ongoing care plan, supports within the community, and the other stresses that you're experiencing are all things that we need to think about, talk about, and work with our patients about. The healthcare system, we've got probably broader coverage now than at any time in the U.S. history, but there are still gaps in that. There are still people that fall out of the system, particularly when you're talking about Medicaid. We have provider shortages. The Medicaid programs that I've been involved with have a real hard time with certain providers. When I was working with Foothills Behavioral Health, that partnership I talked about in the Denver area, they had for a year 10 full-time psychiatrist positions that were open. They just simply couldn't recruit. Part of it is the reimbursement mechanisms, and Um, Part of it is there's just other opportunities out there that um, direct providers to kind of go often where the biggest return on their effort is. So I think that's something that's going to be a challenge. It certainly is not unique to psychiatry. Primary care is a huge challenge for a lot of folks, and even getting other specialists into the network. Virtually all the states require this cultural competency, and it's just another dimension to your recruiting and credentialing that is a prerequisite now, and all of those kind of factor into the quality of care that gets delivered. The benefits, and I think probably everybody watching the webinar knows most of the benefits if you can accomplish all those things. But I think engagement may be one of the most important. The ability to get a patient to commit and engage in their own health outcomes and improving their health, something that a lot of times is lacking. That the actual patient, while that you would think they would have the most motivation to do everything possible to feel well and manage their mobility and all those other things, but it actually takes work to engage them, and it takes this understanding of a lot of those social determinants to figure out what's the best way of communicating and gaining commitment from these folks. The other reality is that patients prefer and get most of their behavioral health from a PCP. So if you reflect back, I think it was like 20% or so of primary care physicians felt that they were well prepared to do that. But often patients just prefer to stay in the primary care setting. So also something you need to incorporate into your planning and training and recruiting. When you do this, when there's a greater awareness of all of the issues going on with the patient, and particularly when the patient is improving, you find much greater satisfaction by both the patient and provider, which is great, keeps people committed to the roles that they're playing. Also, this integrated care approach helps us detect things earlier, particularly substance abuse. A lot of things available in the database now. I think everybody has programs in place to track emergency room use. But the more places where you're collecting data, the more likely you are to have a complete picture of what you need to do on behalf of a particular patient. And aside from just better healthcare outcomes, there's a lot of reasons why delivery systems should care. More and more things like ACOs, HMOs, a lot of the major health plans are going financially at risk. And and those are very competitively bid. They're intended to minimize the cost. They have to be actuarially reasonable. So you can't, as a state, just underprice something and hope somebody takes the money and the risk. But you still have to look at total claims, for example, from prior year, and how could you reduce those costs? How could you better manage that population to produce both better outcomes and reduce costs? So another reason why this whole integrated care approach is really important, to consider every aspect and the potential cost and cost offsets that this particular approach would bring. It does if done properly, produce better care for patients with comorbidities. It doesn't have to be just behavioral health. It improves the efficiency for the PCP due to clinical support from the triad, or the people that are doing case management and all of the others involved in the healthcare system. You can assign tasks, follow up. Often in my work with the private equity banks, they're looking at small companies, technology companies that are doing niche things in healthcare. And so many of those startup folks want to get into the PCP's office. And that always just sets off alarms for me, because when I talk with doctors in general, but primary care docs in particular, they feel that their productivity has dropped by at least 10% in the last 10 years, that they're doing so many other things other than sitting with a patient that that are mandated or imposed on them, that they just don't have the patient face time that they would like. So when I talk to those companies that are talking about, well, if we could just get this technology and this icon onto their laptop or their computer, they could have a referral management system. And I generally just tell them, no, I can't imagine there's a primary care that, except under the most extraordinary situations, would welcome yet another bit of administration into their daily routine. So a real challenge here, and I think for all the organizations that are trying to manage care, we've got to be increasingly thoughtful and aggressive about how we maximize the amount of time that doctors are spending with their patients. We've talked a bit about improving engagement, which leads to better compliance. So I won't go over much more of that. Decrease costs and complications. One of the interesting things I did in my years with United Healthcare, we had a health plan in Columbus, Ohio. It was a group model HMO, and we had United Behavioral Health had a staff model. It was surrounded by a network, but we had a staff model operation supporting that health plan. And we started to look with one of the big pharmaceutical companies, who I think had a secondary agenda of their own, but we wanted to create a series of edits that we could go into the claims database and try and identify people through certain characteristics that probably had an undiagnosed mental health disorder. And out of the 300,000 people that were members of that HMO at the time, this is in the 90s, we identified just under 300 who rang all the bells in terms of the criteria and the edits we ran against our claims database. It turned out they had some interesting characteristics. Their average claim cost, these were commercial lives, by the way, was about $14,000 a year. They had actually multiple medical diagnoses. It was kind of a changing diagnosis. They had a number of ER visits over the course of the year. And kind of ironically, they didn't seem to get better. If you looked at patient status, at the end of the year, they didn't feel well. So we did a combined mental health, physical health kind of assessment with the patients, and looked at it again a year down the road. Most of them these patients then were receiving some form of behavioral health support and treatment. And lo and behold, in 1 year, we reduced costs from $14,000 to $9,000 per person. it's about a 35% reduction in total spend, and the patients actually felt they were getting better. So tremendous potential for doing things right. And technology today is so much more sophisticated, and the mandates for electronic health records make capturing more detailed information easier. So I think the opportunities in this area still are just tremendous and need to be a focus going forward, because it had everything you would want: better care, lower cost, happier patients. Talk a little bit about clinical analysis and social determinants. This slide, I'm sorry for, it's just got a lot of information, even though we cut a number of the branches off of it. But it basically is just a kind of a workflow for how, when you encounter these social determinants, you enter this process of basically an administrative process of helping people by incorporating your knowledge about these issues into their treatment plans and protocols. So I think this is one that you're probably better off just reviewing when you have some time and looking at the flows and things. But it does break down the different elements into these domains and what the components. The earlier slide had kind of a synopsis of this. This goes into more detail, and it's kind of intended as, when you start looking at your systems, where are you capturing this information? Do you need to put together a initiative to make sure that these assessments and other things are actually coming into your case management and the others that need to consider it when they treat? Key performance indicators. These are the major things that the finance underwriting would want in order to determine how you're doing, areas that need work. But obviously everybody is linked extremely closely together these days. So it provides guidance to the medical side, creates reports, information in a format that can be used appropriately by the various components of the healthcare system. So, obviously cost, utilization, quality, pharmacy, preventive things that are going on are key indicators of how a health plan is operating. The trends are obviously the most critical part. Are costs going up? Are they going down? Are utilization of particular services rising or dropping? In some cases, utilization rising could be a very, very good thing, that people are going to the appropriate level of care and using the right resource. In others areas, it could be an indication that there's a gap in your network and people are being pushed to higher levels of care. So really important analyses around how your health plan is operating and how these different components of managing care are interacting with ultimately the statistics that come up on that side. Now, more of what that entails is segmenting your population in a variety of ways. Risk, who are your highest cost members? What is the diagnosis associated with those folks? Do you have a disproportionate number of individuals with a particular diagnosis? Do you have great cost variability in treating those? You want to look at those first line of elements, and then the overall morbidity of your population. It's rare that you talk to any physician or clinic that doesn't have the sickest people. That seems to be the standard, that nobody has the most fit people in their population. But you definitely can stratify and look at, is this a sicker population than most? Really important when you're talking with the state or some other funder about what the appropriate cost is. That allows you to do the next thing, which is project your costs accurately. By stratifying by disease, you can develop specific programs, augment your network, alert your care managers and care coordinators that you need to be much more diligent or innovative around that. Everybody is focused on ER super users. When I once at United, when we ran in California in a Medicare Advantage plan, we saw our top 8 participants, patients, were all in excess, I think, of $2 million. But the top utilizer of all was somebody that had been in the ER more than 200 times over the course of a year. Much of it just based on anxiety and concerns that some catastrophic event was occurring. He also lived very close to an emergency room. And it actually became practical and economic for us to have a nurse practitioner stop by and see him every day. So that's how some of those ER costs can just become astronomical. Now, we had a lot of other things going on as well, but some of these super utilizers can really be an enormous burden on the system. These data inquiries, I think most folks are familiar with this. You just have to be able to look at all of the data associated with medical pharmacy, behavioral health. So this ACG output is Johns Hopkins program that creates analytics and data. It's interesting studies and technology systems that they've created. Other organizations have kind of similar capabilities, but all of these components are important so that you can tell how you're doing and what course corrections you want to make. These customized output files are really critical for a number of things. One, my experience with the 14 states I was involved with at Value Options was they wanted to know all sorts of information: the utilization, hospitals, shifts between ERs, and what are you doing on these things. So you really do need the capability of producing this information for regulators, for financial purposes, and obviously for purposes of continuing to improve your quality of care and care management. So the role of technology, I think we've pretty much defined why you need a good technology platform. It's basically to capture all of the information we've been talking about, so that first of all, you can identify who are the people, who are the risks, what are the factors that we've been tracking that are associated with this particular individual. How then do we construct a plan to engage this patient in their care and commit to their treatment plan? How do we provide our case managers with the information to help drive that successful outcome? Action plans, obviously all the planning and engaging doesn't do you any good if you don't put care plans in place, follow up on them, workflows, periodic risk reassessments, interacting with caregivers, a really important component, and not just within the medical community, but with family members that could potentially or are engaged in supporting the individual, and making sure that that communication is timely, it's done in real time. So many of these things, it's the importance of the moment in order to really have an impact. And then the analytics really kind of related to identifying, but knowing your risks, measuring your performance and your outcome, and proactively reaching out and supporting, intervening in whatever way is necessary in order to produce the best compliance and ultimately the best health outcome. So that's the formal part of the presentation, asking the question, are you prepared to assess risk? One thing I should tell you, you see the InfoMC logo on the on all of the slides. InfoMC is a technology company. I'm on their board of directors, just for purposes of full disclosure, and they had asked if I'd be willing to be the presenter for this. So that is the reason why I'm here. And there's some acknowledgments of folks who I used some of their research. Aaron Halfin is an old friend of mine. We worked together at Centene. He's now the chief medical officer at New Directions, and he had done some research on integrating behavioral health, and was kind enough to let me use a couple of his slides. So with that, Sam, I'll turn it back to you.
Thank you so much, John. That was great information. I know we all appreciated it. I do have a few questions I wanted to ask you, if you don't mind, that have popped up. The first one is, what are the key data information elements that are necessary to effectively manage and coordinate care?
Well, we touched on a lot of them, but the real, starting place obviously is all of the medical, behavioral, and pharmacy claims. Then you add to that these kind of life influences, the social determinants of health. That ultimately results in a treatment plan. And then you have to be able to match that treatment plan to the resources that are available in your community and within your health plan. So all of that needs to be available on a real-time basis. You need to know the decisions that maybe somebody that's managing a particular chronic condition has already done, so that you're not interfering with one another's activity. Everybody has to be on the same page. But having all of that information available in a single database in a usable format, not where you have to be a SAS expert to go in and create your own report. It's got to be something that's that accesses those facts quickly and in a usable format.
All right, thank you so much. The next one is, how do you keep your arms around SDOH when they are outside of the traditional healthcare arena?
Well, I think this is one of the new challenges that our healthcare systems are facing. It really becomes a new role, I think, for network development and for provider relations to identify, reach out, and form some sort of a relationship with some of these organizations that support people, but don't necessarily have a purely healthcare role. All of us, I think, at one point wind up working with housing authorities and those kinds of things, but others are respite care for caregivers who are helping another family member, and um, just elements within the community, um, everything from child care to food services and things that um, historically we haven't gone out and contracted with. They need to be part of what you define as your network, and you need to know uh, what group is appropriate for what individual. So I think it's going to put a significant burden, and it has in the states that have really emphasized social determinants of health, for people to go out and construct these relationships. A lot of the RFPs, once the contracts are awarded, will become public. The bidders have an opportunity to redact stuff, but if you looked at, I would say, New Mexico and Colorado in particular, there's lots of discussion in response to specific questions of how and to whom you're going to do outreach to literally get your arms around the social determinants of health. So people might want to take a look at that. If you have any trouble finding it or want to go into that topic in depth, you can contact the association or Kathy White, and we can get that information out to you.
Thank you for that. And the last one that we have today is, if the cost of care for individuals with comorbid physical and behavioral health conditions is significantly higher than average, how can this information be used to identify people who potentially have an undiagnosed behavioral health issue?
Well, this is exactly what I was talking about with that Columbus example when I was with United Healthcare. You can, you start with people that are, high dollar. That's your first cut. But there's so much more below it, because some people are high cost and will forever be high cost. So because their conditions are so severe and require so much ongoing care that there may not be a lot you can do. Now, many of the high cost people, there is a lot you can do, but you start to look at those edits. The diagnoses. Are their diagnoses changing? Is there a lot of complaints of headache? Just little elements that your medical director and a lot of folks out there, case managers, know, but you aggregate them into, this series of edits, and you look and you say, this person has never been screened properly for depression or anxiety, or was actually referred and never kept that appointment. Then I think you can create a population that is really high potential and high reward, frankly, for everybody involved in it. So that's the key, to identify those people, but have a real strategy to triangulate on who's the best candidate for what intervention.
Thank you so much for that, John, and thank you again for this presentation. We also have Kathy White on the line, who is with InfoMC, and so I'm going to turn it over to her.
Good morning, everybody. And John, thank you for providing the presentation and information. Sam, thanks for letting InfoMC have the time this morning. We're really excited to be part of the Florida ACO Association. As John indicated, InfoMC is a healthcare technology company. We have a highly configurable population health platform. And as John talked about, some important areas that you really need to look at is merging clinical, behavioral health, and social determinants of health. And we know that that can improve care coordination and reduce cost. We also know that you need that as you support taking on risk and moving to a risk-bearing model. So I'd love to talk to you more about it. If you'd like more information, please feel free to reach out, and I'll look at a time to do a demo for you, and I look forward to meeting everybody in the near future, and really appreciate everybody getting on the call today. Sam, I'll turn it back over to you.
Thanks. Thank you again to both of you for your presentation and the information today, and thank you everyone for participating in today's webinar. Once you exit, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. We will also be sending an email with contact information if you have any follow-up questions and a link to the webinar recording. Please feel free to share this link with anyone you may think may be interested, and watch your email for upcoming webinar announcements. Again, thank you all, and we hope you have a great 2019. Have a great day.